Yeah, my name is Ben Hippen. I'm with Metrolina Nephrology here in Charlotte. I'm a transplant nephrologist, but I'm also a general nephrologist. Here are my COIs. None of them are going to touch on anything that I'm talking about here today, but I do some other things. Well, you can read it. I am going to be discussing, I probably should say, off-label use of a genetic test, but it doesn't have a label, so by definition, my entire discussion will be off of a label that doesn't exist. So let's start off with an overview of what I'm going to talk about. I'm going to be talking about APOL1 genetic testing and its implications, particularly in transplantation. So I'll begin by sort of giving you an overview of what I think the stakes of that discussion are, because I think they're high. And then I'm going to move on to talk a little bit about an overview of what an APOL1 gene mutation is and what its implications are. And I say that fully cognizant of being in the room with one of the world experts on APOL1, Dr. Barry Friedman, who will give us his insights later in the afternoon. I'm going to then move on to some taxonomy concerns, particularly with regard to the category of race and what exactly that means with reference to APOL1 gene mutation testing. And I'm going to talk a little bit about the relationship between genes, environmental exposures, and how all those tie together with regard to social determinants of health and how that impacts the phenotype that's exposed in folks who have APOL1 mutations. And then move on from there to talk about some ethical concerns with regard to APOL1 genetic screening on a population basis. I'll start off with giving an overview of some general concerns that come up frequently in genetic screening debates, and then focus particularly in on some issues that might come up in screening both deceased donor candidates and living donor candidates, and then give some very tentative sum-ups, because I'm not fully sure what I think about all this yet. I'd be grateful for your insights and comments. So now you're going to pay for sitting in the back because my font is small and my slides are busy, but that's okay. You can move if you want. So what are the stakes? Well, in general, the stakes are these. CKD and ESRD disproportionately affect the African-American population. Although African-Americans only make up about 13% of the U.S. population, they comprise nearly a third of patients with ESRD in the United States. There's a reduced availability of living donors within the African-American population, in part because of precautionary principle concerns on the part of transplant nephrologists, that is, not wanting to accept as a living donor candidate someone who might have a higher risk of developing kidney disease or kidney failure over time. And this results in reduced total access to kidney transplants amongst African-American candidates with ESRD. That's certainly not the sole reason, but that is a contributing factor, I think. There's also some retrospective data, which I will show you in a minute, that sort of underscores empirically this concern about long-term risks for living donor candidates who are African-American. There's also the challenge that the category of Black or African-American is a social construct. It is not a diagnostic one. And I'm going to talk a little bit more about what that means, because that's not immediately obvious. Just I'm offering you there, but this is the overview slide. So. There's then a question about what the utility of a genetic test is to distinguish subgroups with higher long-term risk for kidney disease. I mean, there are good tests and there are bad tests. Good tests tend to clearly distinguish subgroups that are at higher risk. But the thing about APOL1 mutations is that risk is not destiny. That is, even patients who have APOL1 high-risk mutations are not destined to develop CKD or ESRD. And of course, even good tests have their own drawbacks and unintended consequences, and I'm going to review some of those. Again, no test is perfect, and these tests are often administered by clinicians under conditions of empirical uncertainty, and there is empirical uncertainty with regard to the long-term implications of APOL1 testing, as well as heuristics and bias. What I mean by that is that even clinicians who have a reasonable background in statistics are often very bad at understanding risk and certainly explaining risk. And you add to that a distance in terms of a knowledge distance between a clinician and someone that you're talking to I mean, if a clinician doesn't understand risk very well and can't explain risk very well, it's even more difficult to accomplish what might be thought of as authentic informed consent in terms of talking to patients about this before ordering the test. And who takes on the risk of these uncertainties, these empirical uncertainties, and whose responsibility is to follow through on screening and follow-up and all the rest when you order a test that has this level of uncertainty is an important ethical concern. I won't pretend that I have definitive answers to that today. But, you know, there's sort of two poles of ethical behavior you can approach. One is the precautionary principle approach. This is typically more common in Europe. A precautionary principle approach is that if is a tendency to shy away from a screening test or a therapy if there's risk of even very small opportunities for harm. A precautionary principle approach to APOL1 testing in deceased donors and in living donor candidates would probably entail reduced access to organs for African American candidates, particularly by reducing the number of African American living donor candidates. However, a more permissive principle approach, looking at empirical uncertainty and recognizing that not everybody with mutations will necessarily develop CKD or ESRD, may result in accepting African American living donors who do have mutations who may develop long-term risk over time. But the most exciting thing I think about APOL1 mutations is the opportunity for APOL1 genetic status to supplant the category of race in terms of risk adjustment for deceased donor organs. So, when you get an organ offer as a transplant nephrologist or transplant surgeon, you get a lot of demographic information about the deceased donor. And that data is all collected and collated and analyzed by a central organization called the SRTR, the Registry of Transplant Recipients. And so race remains a category that is included in risk adjustment in terms of figuring out the risk of long-term graft survival. And I think it's one of the most promising aspects of APOL1 testing in transplantation is the opportunity to actually get rid of race as a risk category and replace it with APOL1 testing. I'll talk a little bit about that too. So here, going back to some of the stakes, this is a slide from a study from JAMA about 3 years ago with Alex Massey and their colleagues at Johns Hopkins. This is a retrospective study of living donors going back about 20 years. As you can see, they looked at about 100,000 living donors and found 99 donors who at some point in their life went on to develop kidney failure after being a living donor. And these categories were broken down by ethnicity. And as you can see, African American females and African American males had higher rates of ESRD at 15 years after donation compared to Caucasians. And again, to remind you, though, African Americans make up about 13% of the U.S. population. They make up about a third of the ESRD population. And importantly, they make up a third of all the donors, the living donors who developed ESRD. The proportion of donors in this study that were African American is about 13.5%, which that is about their prevalence in the U.S. population. So the risk of ESRD in African American living donors was triple that of Caucasian males and females. So if there's a gene that might distinguish among this group of people who be at higher risk for developing ESRD after being living donations, that would be very useful from a public health standpoint. So let's talk a little bit about APOL1 mutations. Initially, APOL1 was identified as an association between a gene called MYH9 or non-muscle myosin heavy chain 9. And this was associated with non-diabetic related chronic kidney disease in African Americans. There's an autosomal dominant disorder associated with MYH9 that resulted in FSGS. And there was an overlap between what is, thanks to, among others, Dr. Friedman, an association between what used to be called hypertensive nephrosclerosis, a disease that never existed and doesn't exist, and African Americans associated with MYH9 polymorphisms. More detailed gene mapping of this area showed a stronger association not with MYH9, but with ApoL1 gene variants and chronic kidney disease. ApoL1, I don't have a picture here, but is very close to the MYH9 gene, but actually is not in it. And subsequently, 2 ApoL1 mutations were identified. There's G1 and G2. G1's a coding mutation, and G2 is a base pair deletion. G1's much more common, and I'll talk a little bit about that in a second. Interestingly, G1 and G2 never appear on the same chromosome, so it's unusual to have, although they're close to one another. So there does seem to be an evolutionary fitness advantage to ApoL1 mutations. ApoL1 variants actually code for a factor that forms pores in the lysosomal membrane of a species of trypanosomes called Trypanosoma brucei. And the G1 mutation is found in 38% of the population in a very particular area of West Africa, in the area of Nigeria. G2 is found in 8%. These mutation studies were also looked at in a non-African European population of about 10,000 patients, and these mutations were found in less than 1%. It is autosomally recessively inherited, so ostensibly there's no CKD risk for people who are carriers of an ApoL1 mutation. That is, the highest risk group would be someone who has both recessive or the mutation on both genes. However, there's a larger study in African Americans that suggests that there is a slight increased risk in CKD for single mutation carriers. So that means that either someone who is a carrier of ApoL1 may themselves be at higher risk for CKD, that someone who's a carrier may develop a second hit, some sort of environmental exposure or things like that that may give them a propensity for CKD, or there may be additional mutations, a G3, 4, et cetera, that have yet to be identified but may also confer risk, an area still of some uncertainty. So I promised to talk about taxonomy, and taxonomy is probably a conversation that warrants a lecture all on its own. But for the purposes of this discussion in terms of genetic screening, AA doesn't mean African American. What it really means is African ancestry. And to go back, what I mean is a very particular segment of Western Africa. So African ancestry is not identical to Black or identical to African American, because Black and African American are actually socially constructed categories, by which I mean the category of Black or African American do not imply genetic identity. There is no gene or clusters of genes that are common to people who are socially categorized as African American. In fact, if you take people who self-identify as African American and do genetic testing on this group, you find significant genetic heterogeneity, significant genetic diversity compared to, say, non-Hispanic Caucasians. This is an insight that was actually raised early on in transplantation, when it was noted that self-identified African American candidates for kidney transplantation exhibited substantial HLA heterogeneity, that is, a lot of HLA diversity. And the whole idea of having a category that has biological correlate is that you have genetic homogeneity in some fashion, and that's simply absent. So it's not to say that there's no such thing as Black or African American. Of course there is. It's just what kind of thing it is. And what it is a social construction. It's not a genetic category. And this conflation, this actually fairly easy conflation between genetic categories and socially constructed categories are very easy in common language, but those conflations have significant policy consequences. So, for example, the ApoL1 double mutation, that is the high-risk mutation for developing CKD or ESRD, is only present in about 13% of self-identified African Americans. There's some 49% of African Americans who don't have any ApoL1 mutation. And even among those who have high-risk mutations, who are autosomal recessive, they have a heterogeneous disease course. There are probably environmental factors that for a subset of patients who develop CKD or ESRD, But having the double mutation by no means is destiny in terms of developing CKD or ESRD. And interestingly, folks who have ESRD and who have an autosomal recessive genotype who get a kidney transplant don't have any different long-term outcomes compared if their kidney doesn't have an APOL1 mutation. And the other way around, if you take a kidney from a deceased donor that has a high-risk mutation, and you bracket out the first year of patient and graft survival, so if you just take them from 1 year on, their long-term outcomes, their 5-year outcomes after kidney transplantation are about the same. So this goes back to concerns about precautionary principle and being too cautious in using APOL1. If you start to test deceased donors for APOL1 mutations and decide to discard those kidneys, it means that there's going to be fewer organs to transplant and less access to organs. But again, I think the most important piece of this is to actually treat race as a socially constructed category and get it out of risk adjustments for figuring out organ survival. And APOL1 status of an organ may be a useful way to do that. It may also be a way in which we can more cleanly distinguish within the category of African American folks that are at perhaps higher or lower risk of developing CKD or ESRD. So I've spoken a lot about heterogeneity and overlap. This is a slide that sort of illustrates, based on a study of almost 16,000 patients, the overlap in CKD progression over time, and this is time in years. This comes out to 30 years. And the declining lines here are declines in GFR. The green line is Caucasian patients. The black line with the hashes here are African Americans who have either 0 or 1 APOL1 mutations, so these would ostensibly be lower risk. But the hashtags here show that there's a lot of noise. There's a lot of variability in GFR progression. And then the red line and the red hashes here are the subset of patients who have 2 APOL1 mutations. So 2 things. One, yes, having 2 APOL1 mutations seems to confer in general a higher risk of more rapidly declining GFR, but there's a lot of overlap here. And that overlap, I think, raises the question about a second hit, whether that's an environmental exposure, additional gene mutations we don't know about, or things like that. And that has importance in terms of counseling patients about what these genetic tests really mean. I also want to give a word to the social determinants of health. So this is a study from my colleague Jesse Schold at Cleveland Clinic, who looked at community risk scores. These are scores based on things like median household income and whether you live in a food desert, that is, whether you live within, say, 30 or 40 or 50 miles of a grocery store, whether you have reliable transportation and things like that. And you measure all these social variables, you add up the scores, and you get a community risk score. And the higher your risk score, well, the more risk you have. And Jesse correlated community risk scores to things like waitlist mortality. So higher community risk scores correlate with higher death on the waiting list, fewer access to living donors, more likely to be removed from a wait list, less likely to be preemptively listed, but only slightly, more likely to be inactive on the list, and more likely to be offered an expanded criteria donor kidney. And it turns out that African American patients are disproportionately represented in higher community risk score groups, which has nothing directly to do with genetics, which may have something to do with genetic propensity for a small fraction of patients, which may explain some of this overlap and heterogeneity in terms of CKD, ESRD progress. So what are some salient ethical considerations about ordering a test like this? Well, I mean, it's axiomatic that before you order a test, you ought to know why you're ordering it, how the test will change your clinical decision making, who you're going to disclose the result to, and how you're going to disclose that result, what you're actually going to say to patients, as well as what unintended consequences may arise from ordering this test and then subsequently disclosing it. Among the unintended consequences, possible unintended consequences, are a lot of personal and family anxiety about unknown long-term risks, because a number of the long-term risks with regard to even high-risk APOL1 mutations are not known, whether additional disclosures are warranted to other family members, the thorny problem of misattributed parentage. If you identify someone who has a high-risk mutation and mom and dad perhaps get tested and suddenly it's identified that one of them does not have a recessive gene, maybe parentage is mistaken, as well as insurance coverage with regard to life insurance in particular for folks who end up with high-risk mutations. And here again, need to underscore that even a negative test is not identical to having no risk. There's, while APOL1 does seem to explain quite a lot of the CKD risk in the African American population, it doesn't explain all of it. There may be additional gene mutations that we haven't identified yet, or there may be additional risk factors that we don't fully understand that's not fully explained by APOL1. And then in the social context, I think, again, another thing that probably could spend an entire lecture on, but genetic testing, particularly in the African American population, raises the specter of the sordid history of medicine in the last, let's say, 100 years just to start, of scientific racism, eugenics, and plenty of reasons for mistrust of otherwise well-intentioned interventions such as these. I think that needs to be thought about, certainly what I think about a lot in trying to adjudicate the various risks of this test. And so the challenge is, how do we integrate the empirical uncertainties surrounding APOL1 testing into our professional moral obligations? I mean, in general, when I'm evaluating a living donor, my obligation is to the donor candidate. In our institution, in many institutions, the nephrologist who's evaluating a donor candidate is different from the nephrologist evaluating a recipient. And my view is that our obligations to the donor candidate are paramount and, in fact, much more important than more utilitarian concerns about expanding access to transplantation. And that's certainly an arguable point, but that's my view. Two, empirical uncertainties about APOL1 and its long-term risk is not the same as evidence of accidents, and there is a danger of a certain complacency or being a little more relaxed about long-term risk in patients who have 1 or even 0 APOL1 mutations. Again, it's not clear if this higher risk of ESRD, small as it is in absolute numbers, for African American living donors can be fully explained by APOL1 mutations. So let's talk about what is perhaps the easier case, which is the role of APOL1 screening in deceased donors. Again, if you're dead, your lifetime risk of developing CKD or ESRD is 0. So that seems fairly straightforward. But there does seem to be some utility in screening APOL1 mutations in deceased donors in terms of looking at graft survival and maybe thinking about these deceased donor kidneys a little bit differently. So what I've shown you there is a difference in graft survival with 0, 1, or 2 risk alleles in the donor. However, and I don't think Amber's not here today, is she now? So Dr. Amber Reeves-Daniel at Wake Forest, very nice paper in HAT from a few years ago, looking at higher rates of donor arteriosclerosis on biopsy in deceased donors with 2 high-risk APOL1 alleles. But interestingly, if you exclude the first-year graft failures, I alluded to this a little bit, if you just take those off the table, and you look at subsequent years of graft survival, the graft survival for donors with high-risk mutations and 1 or 0 mutations is equivalent. So it may be useful to pair APOL1 status, particularly high-risk mutation, with donor biopsy, although those of you who are in the transplant world know that donor biopsies, deceased donor biopsies, are quite controversial. They're frozen sections, they're hard to interpret. They probably contribute to more organ discard than they should, but maybe this together might be worthwhile. Again, and some of it has to do a lot with the risk tolerance of individual programs as well, but that might be a reasonable way to use this. There's also a somewhat disturbing case report of a de novo FSGS and collapsing GN in a living donor who had a 2 risk allele, which may add a little more texture to informed consent to a recipient if this, if you're applying it to deceased donors in particular. Again, going back to core principles of genetic testing, if you're ordering an APOL1 mutation screen, the question is why are you doing it, in particular in the deceased donor population? And I think the right reason to do it is for study purposes, is to better elucidate what Dr. Reeves-Daniel, Dr. Freeman have been building on, which is to what are the long-term risks to recipients in getting kidneys from these kinds of donors. I think a less good reason, bad reason perhaps, I might have been in a bad mood when I wrote that. Let's say a less good reason. A less good reason is the assumption that that's going to meaningfully inform recipients today about the long-term outcomes because, again, 1 or 2 risk alleles doesn't explain all the variations in outcome. There's probably an environmental second hit that transpired in the donor before donation, or that may transpire in the recipient after they get a deceased donor kidney, or both, or neither. Again, a lot of uncertainty there. And currently, I might be mistaken, I'm not cutting edge on this, but preemptive APOL1 testing is not available in PCR fashion. It might be soon, it might be now. I see a head being nodded back there. Okay, so maybe it's available, and never mind. But until it's widely available, that's a 48, 72-hour turnaround for the testing, so it would be primarily useful for retrospective purposes. That may change soon or may change now. And again, the key policy question in my mind for deceased donors is not the risk to the decedent, because the decedent is deceased, but it's the risk of disclosing, the obligations to disclose these results to family members. Again, anxiety, the possibility of misattributed parentage and more broader testing. Not really sure what to do with a positive test because it's not clear that any of our interventions for CKD change the natural history in patients with 2 high-risk mutations. And then insufficient reassurance from a negative test. It's not as though you're necessarily off the hook if you don't have these mutations. So what might you actually disclose? I think that it should be undertaken in the course of a research protocol, and Dr. Freeman is going to talk a little bit about a research protocol that's coming online here. I think it should be done in contact with donor biopsy, which we discussed a little bit. And I do think that it should be disclosed in a structured way, and I haven't really thought through exactly what should be said to recipients, but I think recipients should be told something about this. To be honest, other than possibly adjudicating which kidney goes to which recipient, because there are a subsection of recipients on the list who are more appropriate for higher risk kidneys, I'm not sure that's going to influence post-transplant management at the moment. But as we learn more about environmental factors that may trigger CKD progression, that may change as we develop some therapeutic targets. I think a thornier, very interesting set of challenges is APOL1 screening in living donors. There's a clear understanding of why we would do this. In general, we're trying to identify a subset of people beyond simply there's membership in a socially constructed category of African American that would constitute higher risk, and then also offer some reassurance of those that would not be at the same risk. The challenge is that a test like this is an intervention, and once you do it, you can't unknow the result. So the question then becomes, before doing these tests, what further decisions a positive test would trigger, particularly if you have a high risk genotype, but also a one allele mutation. So again, as mentioned, it's not clear whether or not even the best chronic kidney disease management alters the natural history of patients with 2 risk alleles, nor, I'd add, in particular in the case of living donation, is it clear that taking a kidney out of somebody who has 2 risk alleles will necessarily put them at higher risk. So you could imagine, in fact, I don't have to imagine, this actually happens in the kidney transplant world. Someone who is African American, perhaps late 20s, early 30s, who wants to donate to a sibling who has FSGS, and they're interested in getting testing. They fully understand the risks. They come back with 2 high-risk alleles. And they say, well, look, doctor, you told me that, number one, you don't know whether chronic kidney disease management is going to change the natural history of this. I may develop kidney failure either way, whether I'm followed closely by a nephrologist or not. And furthermore, you can't really tell me, right, that if you take one of my kidneys out, that I'm at higher risk for developing kidney disease or kidney failure, or that it will progress faster, right? I mean, you can't tell me those things. And I have to say, well, yes, that's true. I said, well, I want to save my brother. And I understand all of that, and I want to proceed. That's the challenge. That becomes the challenge. And then who takes on the risk? Who takes the responsibility for taking on that risk of empirical uncertainties which conflict with your clinical gut feeling that this is not a good idea? So, there's a question of who gets this information disclosed to, who has control over the information, how widely this information is disseminated, whether it becomes part of the medical record, and the extent to which it imposes additional emotional burdens on a donor who both wants to do a wonderful and altruistic thing, but not necessarily at the expense of their health, even though they're not sure if it's really at the expense of their health. Additional twists are kidney paired donation. So this is now fairly common around the country, where you have a donor and a recipient who are incompatible for some reason, mostly immunologically incompatible, and the extent to which APOL1 testing might become obligatory in kidney paired exchange programs. So all of a sudden, just in order to participate in a kidney paired exchange, you'd have to get APOL1 testing if you fit certain categories, and the downstream unintended consequences of that, which I kind of already mentioned. So I alluded to it a little bit. Should a high-risk genotype be a contraindication, an absolute contraindication of living donation? There's probably some caveats and asterisks there. So one variable to think about is age. If you're younger and you're a living donor, it's just like buying life insurance. If you're 25 and you buy life insurance, it might not cost very much, but there's a lot of things that can happen to you in 50 or 60 years. If you're 60 years old, morbid as it sounds, there's less likely something to happen to you if it hasn't already happened to you. Right? So the real concern is in folks who have high-risk mutations who are young, because there's a lot of opportunities for environmental exposure, a lot of just, opportunities for anything to happen. So Bob Steiner, who's a transplant nephrologist in San Diego, probably writes the best stuff on this, and he thinks that, there's a lot of older living donor candidates that we're turning down because we're concerned that they're older and at higher risk, and in fact, that probably the opposite is true, and that there may be some correlations there with APOL1 screening. Again, we don't know whether or not reducing or taking a kidney out of somebody really increases their risk. There's been a lot of more attention to psychological risks of living donation of late, particularly ambivalence between the living donor, and the recipient. And this adds, I think, just yet another reason for anxiety. And then there's, again, the possibility of thus far undescribed mutation. So I think no is the answer to that question, that too risk or a high-risk genotype should not be an absolute, but should be a relative contraindication. That additional clinical risk factors, which I describe here, probably would push it for me to become an absolute contraindication. And then this is a very difficult one. I really struggle with this, but I do think that there's a role for taking into account social determinants of health. Folks who live in high community risk score communities, live in food deserts, live in medical deserts, are at a high likelihood of getting many of their meals out of a box or a wrapper, and likelihood of future environmental exposures. I think that those are real risks. They're risks whether you have a high-risk genotype or not for APOL1. But I think if you do have a high-risk genotype, those are almost certainly the best candidates for environmental exposures that will result in progression of CKD and ESRD. But look, the implication here is that you are talking about creating a subclass of African Americans that you're going to say no to as donor candidates. I mean, that's not a trivial thing, and I get a little nauseated just saying it. But I think it's this is this is why these ethical questions are a struggle, because they don't sort of just take place in the abstract. They take place in context of a important social context that I kind of discussed already and won't linger on. I think the better way to think about this problem is to reverse it, that instead of having a test and looking for an indication, it's identifying a question that could conceivably be answered by a test. So for example, you can offer but not require testing for self-identified African Americans interested in being donors, design a good disclosure process in advance, make a plan in advance of what you're going to do with this information, whatever it turns out to be, and discuss how a positive test might impact a donor's decision to donate before you get the test. Before you get the test, that's key. That's key. I think that APOL1 testing can be useful as a final straw for donors you're on the fence about in terms of risk. But there remain empirical uncertainties here, particularly with regard to one-risk allele carriers. And then I think, again, probably the most important use for this is to do it the way Dr. Friedman and colleagues are doing it, is offering APOL1 testing as part of a longitudinal study to answer some of these questions so that we can better fill in the blanks in terms of informed consent. So in short, well, it wasn't short at all, was it? But in sum, how about that? That's better. In sum, it does have benefit. Screening does have benefit in specific contexts. It would be a welcome replacement for the category of race in terms of risk stratifying deceased donor organs. It's definitely better for fleshing out what the long-term risks really are for a population that we need to know a lot more about. And with some caveats, stratifying risk for African American living donor candidates. But there's a lot to think about here in terms of the broader ethical issues with regard to disclosure obligations, privacy, who has control of the information, who can use this information for other ends like jacking up life insurance premiums, stigma, and again, our trials transpiring in this social and historical context. And figuring out not only what we know, but what's left to find out about the relationship between the risk for CKD and ESRD in African Americans. And key to this is developing screening protocols and disclosure protocols and informed consent protocols in conjunction with community consultation. I think that's really, really important, something that was missing in the past and something that needs to be ameliorated for the future. And control of this data, really important, thorny policy problem. So that's all. I want to thank Dr. Friedman for looking at these slides and his critical commentary, and stand on the shoulder of others. These two gentlemen at the University of Alabama in Birmingham trained me in transplant nephrology, and I owe them a great deal. That's why I'm here. So thank you. Take your questions. Ma'am.